I'm sorry, with delivery of health care in rural areas, and that has to do with the 2009 CMS ruling, or policy, I guess I should say, regarding direct physician supervision of outpatient therapeutic services. Hospitals, physicians, and rural health care organizations recognize this change as a burdensome and unnecessary policy change, but CMS characterized the change as a, quote, restatement and clarification, unquote, of existing policy in place since 2001. In its attempt at clarification, CMS retroactively interpreted the policy to require that a physician privileged by the hospital provide supervision and be physically present in the same outpatient department at all times when outpatient therapeutic services are furnished, when historically that has not been the practice. I'm concerned that CMS's, quote, clarification is instead a significant change in Medicare policy that would place considerable burden on hospitals, especially facilities in rural areas. And I'm also concerned that the panel convened to advise on this issue is not sufficiently considering the input from rural critical access hospitals. And my question is, will you agree to return to the pre-2009 interpretation of this policy?
Well, in 2009, you are correct that CMS made some, what we called policy clarifications, but what I believe the critical access hospital community interpreted as fundamental changes. We heard a lot of concerns. We heard a lot of complaints. In 2010, I traveled through North Dakota, not South Dakota, but North Dakota to meet firsthand with critical access providers, and we heard tremendous concern regarding the challenges that our clarification would provide critical access hospitals. We decided to back down, to slow down, to create this physician hospital provider review panel to help us understand which services don't require direct physician supervision. That is the framework that we're moving. My understanding is that it's working better from the critical hospital's perspective. I would love to hear your views, how we can improve that, but I believe that we are working to address the concerns that we heard during 2009, and seeing the hospital care firsthand was very helpful for me to understand how to work together with the hospital community to solve this issue.
I'm glad you went out and got some of that perspective, and we'd be happy to provide feedback that we get from providers in our part of the country, because it's a really important issue in terms of delivery of health care.
Absolutely.
Your testimony outlines a long list of initiatives that CMS is implementing with the goal of improving health outcomes and lowering costs. The question is, if these proposals are going to significantly, or sufficiently, I should say, lower health care costs for taxpayers and patients, why is the Independent Payment Advisory Board necessary?
Well, the independent board is outside of CMS, is my understanding, so I can't speak to it directly. What I can say is, from the person operating the Medicare program, it is tremendously helpful to have pressure from Congress, from outside boards, to keep spending low. And we work in CMS to ensure that we're building policies, to keep spending low, to ensure quality is improving at the same time. But having that system of checks is tremendously helpful to ensure that we're pushing on all of our payment systems in a way to maximize quality but to reduce total cost of care.
But it doesn't sound like it's all that necessary for you to accomplish the initiatives, the things that you're trying to accomplish here. Those are things that CMS is doing on its own.
What I would say, Senator, is that this focus needs to continue. The pressure needs to stay on, and there's multiple ways to receive that pressure, but having that pressure is the best way, in my judgment, to continue the focus that's been there for the past several years.
Last question has to do with electronic health records and the rate at which CMS is implementing the Stage 1. In the last 6 months, I think Stage 1 has been implemented. They're published a final rule for Stage 2 and already seeking feedback on Stage 3. There are still a lot of reports out there that question the effectiveness of EHR adoption. And my question is, do you believe that CMS is conducting appropriate data review before accelerating into Stage 2 and Stage 3 to ensure that that program is on an appropriate path towards interoperability between unaffiliated health systems or providers?
Well, I think a couple of ways to answer your question, Senator. We are pleased with the rate of adoption of hospitals and physician practices to respond to these new incentives. One of the things that we hear from entities that are participating within our new delivery models like ACOs is that the model wouldn't be possible but for a strong electronic medical record. So I believe that we have to evaluate the impact to the EHR program, not just the program itself, but the total changes that we are seeing within the healthcare delivery system. So hospital readmissions coming down, that's a sign to me that healthcare systems, healthcare silos now are talking to each other better to reduce the lack of care coordination. We are committed to oversee the program. We're happy to work with you and your staff to best understand how we can best oversee. We are also concerned about some of the reports that EHRs may lead to inappropriate spending or services. We take that concern very seriously, but we are committed to ensure this program continues to expand while also preserving the integrity of the programs.
Thank you. Thank you, Senator.